Ladies and gentlemen, we now begin Symposium 23, dedicated to medical education, with discussions on undergraduate assessment, clinical reasoning, and shaping the future physician on humanism, AI, and the art of clinical wisdom. I am delighted to invite our chairpersons, Professor Gominda Ponnamperuma, President of the College of Medical Educationists, Sri Lanka, Professor Indika Karunathilake, and Professor Vajira Dissanayake. May I now invite our chairpersons to introduce the speakers and panelists for this session.
Good afternoon, everyone. It's indeed a pleasure to be chairing this session with two very important people for myself because I happen to be the Dean of the Colombo Medical School and my head of medical education is next to me, and I know the Vice Chancellor, who is also a medical educationalist, is going to join us. Both of us were welcoming our new batch of students, and I gave the talk before him and came, and he's probably talking now, and he'll be here with us in a little while. But this is so very important because of two or three very, very important reasons. So, I also happen to be the president of the Sri Lanka Medical Council, and Gominda also happens to be the head of medical of the accreditation unit at this Sri Lanka Medical Council. And over the past few years, we have gone through a process of accrediting our medical schools, and based on what was highlighted during that process, which eventually ended up with us becoming our accreditation unit being recognized by the World Federation of Medical Education. So the end result of that was we were able to highlight the deficiencies in our education, our programs, and also get our medical schools to reflect on what the future is, a future where technology is going to dominate, digital and artificial intelligence and so on. And as a result of that, virtually all our medical schools are now in a process of looking at their curriculum, and some even coming up with a brand new curriculum. And so in, for example, Colombo Medical School, we have embarked on that journey. We don't want to tweak around. We want to, come up with an entirely new curriculum, which is fit for purpose, which will, produce the doctors of the future with two aspects broadly in mind. One, of course, the all the innovations that are happening, but not forgetting the human qualities as, what should a caring physician be. And so these are the ideas that are going, everybody is thinking on. And so going forward, there's a lot of learning that we are all, as a country, medical education community in our country is, engaged in at the moment. And we are indeed very, very happy that Professor Prasad Katulanda, together with his college, gave very much prominence to this symposium. So we are really happy that we have this symposium on medical education. So to begin with, so as you know, we have three speakers. We will have Professor Brian Angus talking to us on undergraduate assessment. That is a big, area for all of us. What is assessment going to be? Or are we going to do away with all assessments and bring in a different form of assessment? And there's a lot of reluctance on the part of our academics to, embrace change in that area. Then clinical reasoning and bedside teaching. Professor John Woller from USA is going to talk to us on that, and that is also a very important area for us because we want our students to get the best out of our clinical exposure environment. And then, of course, our own Dujeepa Samarasekera will be talking to us on shaping the future physician, Humanism, AI, and the Art of Clinical Wisdom. So it is going to be a feast of medical education in the next 1.5 hours. So to begin with, let me request Gominda to introduce and invite our first speaker.
So the first speaker is speaking on undergraduate assessment is Professor John Angus. Professor John Angus is the director of the Oxford Centre for Clinical Tropical Medicine and Global Health and reader in infectious diseases at the University of Oxford. Let's welcome Professor Angus.
Hi there. Thank you very much for asking me to talk on one of the other aspects of my job, which is as clinical tutor in medicine in the Nuffield Department of Medicine at Oxford University. Very pleased to say there was another list of medical schools published in the UK in The Guardian, and Oxford came out as top again. So very pleased about that. These things are important these days. So I'm going to talk really about what's been happening for assessment in the UK, and there's been some very large changes in the way that we assess undergraduate medical students in the UK. So just to say that the views are my own and don't reflect the views particularly of the Medical Schools Council Alliance. So the development of UK medical licensing dates back quite a long time, and there were lots of different bodies that licensed doctors in the UK, including the Worshipful Society of Apothecaries, of which I'm also a member. But the GMC really gradually became the sole regulator of medical licensing over a period of time. There were some other things introduced, particularly postgraduate with revalidation, but more and more formalisation of what was considered to be good medical practice and also assurance about patient safety. And in the background to this, there were thoughts to try and introduce a licensing entry exam to postgraduate training from the GMC, and that became known as the Medical Licensing Assessment. The background to this was actually a little bit controversial. The GMC was taken to court because it was felt that the PLAB assessment, which allowed international medical graduates to gain entry into UK training, was considered to be discriminatory since it reassessed people's medical undergraduate knowledge. And so the idea of the MLA was really to try and bring everything together so that there was one separate qualifying exam in the UK that allowed you to go into early training. So just to remind you of some of the things in UK medical training, if you're not sure. So medical degree in the UK is usually 5 years of undergraduate entry. At Oxford, it's 6, and that's because we do an extra sort of intercalated degree, and a lot of other medical schools do that as well. There's also graduate entry medicine, which is a 4-year accelerated course for people who already hold a bachelor's degree. Oxford, we insist that that bachelor's degree is in science. And then once the students graduate from medical school, they then enter the foundation training programme, which is a 2-year course run within the NHS and by Health Education England. And all doctors have to complete this 2-year foundation, F1 and F2. And they provide general training and experience across a whole range of things, including medicine, surgery, but also community, obstetrics, psychiatry, all these kind of things. And then once completing that, you're then eligible to go on to core training, either medicine, surgery, radiology, whatever, and then higher specialist training. And then upon completion of training, you apply for a certificate of specialist registration. So the GMC was very keen to introduce this medical licensing assessment to establish a common standard for safe medical practice and ensuring that all doctors, regardless of their training location, meet the necessary knowledge and skills before joining the medical register. Now, as I said, there was some controversy about PLAB, and so the idea was that there would be one individual assessment that everyone could sit, irrespective of where they trained. One of the controversial things, though, of course, is that previous to this, all universities offered a degree. All universities set their own curriculum, they set their own assessment standards, and of course there is variation between medical schools within the UK. So the universities were a little bit reluctant about this. And of course, the other thing the university said was, well, we don't want to just be a vocational training thing where someone else is setting the exams, setting the standards, setting the curriculum, and all we do is churn out people who pass your standard. We want to do something else. So the Medical Schools Council was involved by the GMC to help to set some of the assessments that people would do. And in fact, although the MLA is the licensing assessment, you also need a medical degree. And of course, there may well come a situation where someone passes the licensing assessment but fails the degree, and they will not be allowed to proceed with training. That area is a little bit grey at the moment, and there may well be some court cases to try and sort that out in the future. So there was a need for a common threshold. As I say, there was variation within UK medical schools and variation in training internationally. And so the MLA was supposed to address this. The GMC, of course, said that they wanted to have patient confidence, that patients could have confidence in the unified assessment. And I think patients were very surprised that there was such variation in training as undergraduates. And they wanted to have consistency across lots of different things. The other thing medical schools were a little bit worried about is, of course, if you have everyone sitting the same exam, you can then rank medical schools according to performance. And the GMC have been very clear that they will not release information on individuals' performance, unlike the US system, for example, but they may look at data related to performance of medical schools. The other thing, of course, that this brings in is that the standard 5-year course that's been available in the UK doesn't really need to happen anymore. All you need to do is pass the MLA. That's led to some ideas that perhaps you could have a 3-year medical course. And one of the universities, particularly in East Anglia, has been piloting this to have a 3-year course. The other thing is you can have a private medical school. It doesn't have to be attached to university. And so you could go through a private medical school training, pass the MLA, and then you get on to postgraduate training. So it's quite controversial, and things are starting to sort out. So getting back to the assessment itself, the MLA basically was put in 2 parts: an applied knowledge test, which is administered really by the Medical Schools Council. The GMC provide oversight to that, but it's run by the Medical Schools Council. And then clinical professional skills assessment, which basically they allowed the medical schools to run that themselves. So we always did OSCEs, structured clinical exams for students, and the GMC have allowed medical schools to continue to do their own OSCE. So there is quite a bit of variation in it. So for example, in Oxford, we use patients, we use real patients with real conditions, and the students examine them. Other medical schools use surrogate patients or simulated patients who are actors or members of the public. But the GMC now inspect the medical school assessment side of things. Previously, the GMC inspected medical schools about their curriculum and how they were teaching, and they now also give you a certificate to say that you satisfy them for the CPSA. But I'm not really going to talk much more about the CPSA. As I say, there's quite a lot of variability, so it isn't as much a standardized assessment as might have been thought at the beginning. So, students in UK medical schools, as I said, will sit the MLA. This has now become the only route into foundation for UK graduates as of 2024-25. And they will set this as the AKT, which is set and coordinated centrally by the Medical Schools Council, but delivered by medical schools, although everything is very standardised for the AKT, and it's regulated and quality assured by the GMC. And then the CPSA, as I said, has been left up to the medical schools to organise themselves, but it must comply with the GMC requirements, and the GMC inspect. And as you can imagine, you have to provide a lot of paperwork on quality assurance for the CPSA, which is taking us quite a long time. That then leads in the UK to provisional registration. So F1 is provisional registration, and once you've completed F1, you then have full licence to practice, but you need to complete F2 in order to go further into medical training. So the requirements of the MLA, the GMC have issued a content map, and also other documents related to the requirements for the AKT and also for the CPSA. And again, this, for the first time in the UK, really standardises what medical schools will teach. Previously, again, there was no national curriculum. Every medical school could do whatever it liked and teach whatever it liked, but there's now this standard requirement for the MLA. And so we've had to redraw our curriculum in order to meet the MLA content map. And of course, the students are very keen on this as well. They see what's there and they basically ask, is this going to be in the exam? As all medical students do. So what's the content map for? So it's the core knowledge, skills and behaviours needed for UK practice. And both the AKT and the CPSA should derive from this content map. And it's got a lot of different purposes for different audiences. For medical schools and GMC, it's the basis for the sampling strategy for the assessment, and it also provides a reference point for developing the CPSA as well. And again, we have to show that it meets the GMC standards and that we sample parts of the curriculum and test them in our assessments. So how did people decide what the content map should be? So there was a lot of discussion even from 2018 with the GMC publishing outcomes for graduates that set out what was expected for newly qualified doctors in the UK, and also the generic professional skills framework. And we also added in some of the things that are in the foundation programme curriculum and some of the problems that particularly we found that graduating students were finding when they reached the UK foundation programme. So the MLA content map is organised into different domains. So there are areas of clinical practice, so mental health, surgery, medicine, the older adult, patient presentations with a long list of things that people might come across, and then a list of conditions. Again, very specific things within the curriculum document. So for my specialty, infectious diseases, there is a section that says they should be asked questions about measles, for example, very, very specific. And then there are the clinical and professional capabilities, approach to patients, how to assess and manage risk, and also things like safeguarding for vulnerable patients. There are also the practical skills and procedures, again, usually related to work in a mannequin in the clinical skills training. And then there are areas of professional knowledge as well, so things like ethics and law and general biomedical science. So in order to produce this assessment, which is, of course, a high stakes assessment, the MSc, Medical Schools Council, worked in partnership with all of the medical schools, and to say there was a bit of unhappiness among some of the universities to support the development and delivery of the AKT. Oversight is provided by Medical Schools AKT Board, which includes all of the heads of the UK medical schools to ensure that the exam is fair and reflects what their students are being taught, and also assurance of quality. And there are several operational groups within, and each has a specific focus. So this is the sort of structure of things, and you can see that there are various groups. I'll talk through a few of them later, but there are item writing groups, there are item development groups, so once questions are written, there's development further to that. The standard setting panels, I'm on both of these, writing groups and standard setting, and then there's a further standard setting group. There's also an exam construction group, although a lot of the exam is constructed with computer algorithms. And the various policy groups, and security, of course, is very important. So the AKT policy group has developed a national framework to help guide local medical schools, and all of the policies have been put in place to facilitate a national assessment. There was a lot of debate about timing, because some medical schools, for example, teach obstetrics in year 4, others teach in year 5. And so to allow some flexibility in the timing, it was originally thought that basically we just have it open the whole time. But of course, exam security meant that you couldn't do that because the exam would be leaked. So now it sits twice a year. And medical schools can choose at what stage their students are most able to sit, which part of the assessment. I'll show you later. Also, the rules that apply to the number of attempts are still governed by the university, as are exceptional circumstances and mitigating circumstances. So medical schools, again, this has been a bit of a thorny issue for reasonable adjustments for students. And again, it has to meet the university policy. But the Medical Schools Council review applications for reasonable adjustments. In general, the MSc accepts any decisions made by the local medical schools as long as they can be accommodated with the exam structure, so people needing extra time. In order to facilitate the delivery of this exam, the Medical Schools Council actually developed a platform for assessment called the Exam Right platform. And it can accommodate a lot of different timings and things for people who need extra time or rest breaks and accessible text. So we've been doing things like text-to-speech, for example, which allows people to be able to talk to the browser in order to put in the thing. And we've developed a dyslexia font that increases readability for students. This is the dyslexia font. So, as I say, the policy group is still working along with medical schools and universities to align their approaches to mitigating circumstances. Again, trying to ensure fairness between different universities. But as I say, every university has its own policy. So the individual decisions are ultimately made by the student's own university. Security, obviously, is a big thing. A couple of years ago, one of the medical schools in Glasgow, actually I was external examiner, one of the students left their phone after the first sitting of their OSCE, left their phone in the canteen, and someone handed it in, and as they handed it to the examiner, it popped up saying, answer to question 1, AF, answer to question 2, ST elevation IMI, and that resulted in about 36 students who were all part of that WhatsApp group sharing answers with each other being asked. One of them was last to leave, and the others had to reset the assessment, but the whole assessment was stopped. So exam security is very, very important, particularly when you've got a national exam, and also when you have it being sitting in different dates. So the Safe Exam Browser is considered to be very secure. They use a lockdown, so students, one of the other problems we found was that there aren't many medical schools that can have 300 desktops in one area in order to be invigilated. So there's allow for students to bring in their own laptops. Some of the software with the Exam Right browser, the Safe Exam Browser, allows you to lock the laptop down so there's no access to the internet. And people come into a hall with their own laptops. Then becomes a problem with how many power cables, and students, again, don't charge their laptops before they come in to sit it, so they're at risk of running out. So all of these things, all these practical things have had to be dealt with, and of course it's always changing. So things like wearable devices and technology and all these sorts of things. So there's an annual cycle that we're now starting to get into with the AKT. So we start off writing new questions, and you can write new questions directly into the Exam Right browser, which is very helpful. And the Exam Right browser actually, it orders, for example, alphabetically the answers that you want. It also allows you very easily to put in tags onto the questions so that they can be sorted out and blueprinted later. The exam's actually constructed by an algorithm, and there's been quite a lot of research now about exam performance, because then if you think we're about 10,000 students sitting this exam, you've got some power then to look at different aspects of the performance of questions, what exactly they're testing, how exactly they work, and what the best questions are. So the exam's reviewed by the quality assurance, by the exam construction group, and then reviewed again by the board, and then standard set, and we use an Angus method for standard setting. So the exam comprises 2 100-item papers over 2 days. The questions are in the single best answer format with 5 answer options. Standard time is 2 hours. Additional time is available, and all contents are aligned and mapped to the MLA content map. So this is the construction. You can see paper 1. As I say, we had to separate things a little bit because medical schools teach at different times. But this is now determining how we are going to teach, in fact. So paper 1, things like cardiovascular, respiratory, gastro, gerontology, important basic things. And then also things like neuroscience, ophthalmology, endocrinology, renal, infection and dermatology. And then paper 2 with some of the other things that are taught maybe at a slightly different time in some medical schools, things like cancer, things like child health, mental health, obstetrics, sexual health, and we include things like medical ethics and law within that, as well as some of the surgical specialties as well, sort of perioperative medicine and that sort of thing. GP, acute medicine, acute surgery, and clinical imaging are across all 4 of the clusters of these. So it's delivered by the ExamRight platform, and the schools have access to this. We ran some pilots and we made sure that all the software was working, although there are still occasional failures, and the executive do spend their time on call when the exam is actually running. And some medical schools have adopted this platform, so it's so useful for actually non-AKT assessments. And also we provide practice papers, for example, to students to be able to work on in preparing for it. So the students should be familiar with the platform when they come to do it. So to say that again, this just shows there are about 40 members, author, review about 600 items each event, and the current database is about 6,000, but each time we do something, we add probably about another 600 new items. So we want to keep increasing the database, but we also want the questions to get better as well. And so we have some software analysis of the questions performance. So standard setting with a modified Angoff, and again, we do this in clusters with about 40 people contributing to the process, and we take various bits of the exam in order to standard set. So as I say, the exam board, when it actually runs on the days it's running, there's a rapid response team with their mobile numbers, and they're on call during the exam periods. And then it takes about 14 days to analyze the papers, and of course occasionally there are surprises. Some questions don't perform very well, some questions just are too easy or may have leaked. So the board meets for the post hoc analysis to look at the results and ratify the results. So we share the information with the medical school staff with some guidance material and also plans for managing incidents if anything happens. There are electronic newsletters, there are dedicated points of contact, and the websites have lots and lots of information in them for students, but also for staff. And as I mentioned, there's a 200-item practice exam and other practice materials and familiarity with the platform. So the results are delivered to the students through the medical school. Again, quite important to have that sort of closer point of contact rather than a sort of faceless national board. They're not directly released to the students, and the students basically are told if they pass, fail outcome, along with a score and some feedback in each domain. So this is automatically generated so they can see, for example, if they don't know any infectious diseases, which is a disaster. The results are all uploaded to the student record, but it's categorized as pass, fail, merit, or distinction. Again, there's been some debate about whether the students should be ranked in order when they apply for the foundation school post, but that's been resisted at the moment. But there are ways the GMC can look and see how medical schools are performing overall and whether there's any big outliers. So that's the final slide. And as I say, this introduction has just been in the last year, that all of the UK medical schools have to sit the same exam and use the same curriculum, but has been piloted really for the past couple of years, probably about 4 years, where various medical schools voluntarily signed up to do it. Some medical schools ran it in parallel. Some medical schools sampled part of the bank in order to run their own exams. But the last, fingers crossed, few runs of the assessment have gone very well with no particular problems. Thank you very much.
Thank you very much, Prof. Agnes. That was, a lot to digest, I think, for all of us. And we need a special session with you, and we'll strive to, arrange that. I think I'm sure Prasad will facilitate that. Let me invite Professor Indika Karunathilake to introduce our next speaker.
Thank you, Professor Vajira Dissanayake. Now it's my pleasure and privilege to introduce Professor John Woller. Professor John Woller, MD, is a general internist practicing the Johns Hopkins Hospital in Maryland, USA, and he has completed medical school and Emory School, University of Medicine in Atlanta, Georgia, and internal medicine residency in the Osler program in Johns Hopkins. The name of Osler is something that medical education and medicine can never forget, and going with Johns Hopkins. And now he is the Associate Program Director for Bedside Medicine for Osler Medical Residency Program. And he'll be talking about the bedrock art and science in medical education, where Sir John Osler was a pioneer. And and art and science that need renewed interest and focus in this era of artificial intelligence. Clinical reasoning and bedside teaching. Professor John Woller, please.
All right, good afternoon, everyone. Thank you so much for the opportunity to speak today. I'm going to start my talk with an image which may seem unrelated to medicine. This is a teacher and a student at the piano. In the US, our education system is a little different, and medical education is strictly postgraduate. And so my undergraduate degree was in classical piano, so I would not have been admitted to Oxford Medical School for multiple reasons, that being one of them. But this is a student performing and then a teacher alongside coaching, also at the keyboard. And I didn't know it at the time, but I was learning a model of apprenticeship when I was studying music that I think is really applicable to medicine. So I'm going to talk about teaching clinical reasoning today, and I'm going to make the argument this is something we should do at the bedside in the context of the patient's care. I have a couple of learning objectives to frame my talk. I have no financial disclosures, unlike some of the folks pictured here. So I'm going to frame my talk around a case. This is an actual case of a young man, a 21-year-old, with 2 days of large volume diarrhea and fever. And I chose this case because it's one that my house officers got wrong, and there were some opportunities to teach. So how can you provide clinical reasoning to your interns or your registrars in the context of this case? And it's going to be a very straightforward case for most of you, I think, but that doesn't mean it's not rich with opportunities to learn. So I think we can actually teach the diagnostic thought process, or what we call clinical reasoning, at every phase in the patient's care, from the history and physical to their triage, order entry, lab interpretation, imaging, formulation of their assessment and plan, and then, of course, the presentation, which is when we typically quiz our learners about their patients. I want to make an important point here. If we don't gather the correct information from the patient, we're not going to get the diagnosis. And I think this is increasingly important as artificial intelligence is starting to be able to generate a differential diagnosis and to process information reasonably well. It's still not that good, but it probably will be soon. But if we give it the wrong information, it's going to give us the wrong differential diagnosis. So we have to do an accurate history and physical. And it starts really with the history, which is still where we get the majority of the information that we use in making a patient's diagnosis. In my context, where we have every technological test and intervention you can imagine, still the history makes the diagnosis over 75% of the time. So, is history taking clinical reasoning? Well, you've all already started to form a differential diagnosis about the patient I told you about, just from the information that he's a 21-year-old with 2 days of abdominal pain and diarrhea, right? And so we have to recognize that this is something that is ongoing from the moment we meet the patient, especially those skilled in observation. Without even saying a word to the patient, we'll already be thinking about what this person has. So we have this sometimes idea that we gather information and then we sit down and think about it and form an assessment and plan, but that's actually not how we work at all. We're doing this all in parallel as we meet the patient and talk to them. And the questions you subsequently ask and the exam you perform is going to be influenced by your differential diagnosis, right? None of us are going to do the exact same history or the exact same physical for every patient. We have a template, but we don't have, the same set of questions we ask everyone, right? And the differential diagnosis is going to evolve during the conversation as well. But how do we teach this? For many of us who have been practicing for a long time, it's intuitive. So how do we teach this to our learners who are just, understanding why we do what we do? Well, the first thing is to model good practice, right? To show them the proper way to do this. And then, importantly, articulate our thought process and say, why am I doing this? And then we'll also use questions to make sure our learners understand what they're doing as well. And I'll touch more on that later. So here's the history that we got, which was pretty good. He had one episode of blood and stool the day of admission, had nausea but no vomiting, poor appetite for 2 days, had sweats and chills, had not measured his fever, and his sister was sick with a similar illness. He had no report of sexual activity at any time in his life, no reported non-prescribed substance use, and his abdominal pain was moderate to severe, but he was still able to carry out his daily activities. So, moving on to the physical exam. You may have heard the phrase, the the eyes don't see what the mind doesn't know. I think this is a misquote of D.H. Lawrence, who said what the eyes don't see and the mind doesn't know doesn't exist. But the concept is there. We have to be looking for things in order to find them. Same question as before. Do you do the same physical exam for every patient you meet? I hope not. We are tailoring our exam to our differential diagnosis. But how do we teach it? Again, model good practice. Let your trainees see you doing a good physical exam. Don't put the stethoscope over the clothes, right? Don't use your stethoscope as a reflex hammer. Do it properly. Doesn't mean you have to do the entire exam with the team, but what you do should be proper. And then articulate your thought process. Yet again, tell them what you're thinking and why you're doing it. I really like this resource, which is Steve McGee's Evidence-Based Physical Diagnosis. And I think we can actually gain a lot of trust from our trainees if we use an evidence-based practice, right? So we're not doing an exam maneuver because it was what our attending told us when we were an intern, right? There's a lot of outdated physical exam teaching out there that may no longer be applicable or that we have better evidence to suggest is not very valid, right? And so this textbook has a lot of really great information about the actual likelihood ratios associated with physical exam findings. And this is Bayesian reasoning in the context of the bedside encounter. So as an example, for this young man with abdominal pain, maybe we're worried he has peritonitis. And so what we can see here, and I'm sorry there's a lot on this slide, is the positive likelihood ratios in this column, the likelihood ratios in this column if a finding is present, and then the likelihood ratio if it's absent. So likelihood ratio greater than 1 is going to increase the likelihood of the diagnosis, in this case peritonitis. Less than 1 is going to decrease. And so what we're seeing here is that there's not a lot of findings actually that are going to significantly increase or decrease the likelihood of peritonitis by themselves when we're seeing a patient with abdominal pain at the bedside. Rigidity, importantly, does significantly increase the likelihood. And if we add up multiple other likelihood ratios, including guarding and tenderness with percussion, that can also get us significantly more concerned. Whereas if they have a positive abdominal wall tenderness test suggesting a focal musculoskeletal or nervous syndrome, that decreases the likelihood. And then just to put another graph on it, these are the findings and how much they would increase or decrease our probability based on a pretest probability of 50%. Now, importantly, if our pretest probability of peritonitis was 99%, then our post-test probability wouldn't be significantly decreased by one of these negative tests, which aren't all that good, right? Whereas if our pretest probability was 1%, and then the patient had a rigid abdomen, still we would not be in a very high post-test probability world. This is a very brief introduction to Bayesian reasoning. But the point is that if we use data in our physical exam teaching, and if we use resources like the JAMA Rational Clinical Exam Series and other things to teach our trainees, this is the evidence behind these findings that can increase their faith in the exam and also make sure that we're actually doing an evidence-based exam. Now, these are not perfect numbers, right? These studies don't perfectly encapsulate every patient and every encounter, but I do think it's a valuable resource. All right. So let's move on to the actual examination of our young man with diarrhea. So he was found to be febrile, 39.1. He had a normal blood pressure, heart rate was 110, his respirations were 20, and his oxygen saturation was normal. He had a diffusely tender abdomen, but with no peritoneal signs, no rigidity, guarding, rebound. And the rest of his examination was essentially unremarkable: cardiovascular, pulmonary, extremities, and skin exam. He did have a nice examination looking for extra intestinal manifestations of inflammatory bowel disease, which is what my house officers thought the patient might have. And he had no oral ulcers, uveitis, no digital clubbing, and he had a digital rectal exam that was painful, but without any other concerning findings. He had blood consistent with his report. So they did a pretty good exam, I think. I'm going to pause in the case to just talk about a couple of concepts that I think are also very important. As we're thinking about building trust with our trainees and also empowering them to express themselves freely. I really like this book. It's a book on adult learning theory. It's not specific to medicine, but it is solid science in terms of how people learn, right? And so a couple of things. One is that we want to explain not only our thought process, but also how we know things. So we don't want to pretend to be bulletproof or pretend to be invincible. I think demonstrating humility, telling our house staff, oh, I looked this up this morning and here's what I found, or I don't know the answer to this question, here's the resource I'm going to use. I think that's much more valuable than pretending that we know everything and just expecting them to give us all the information, right? Because it also teaches them that we're lifelong learners as well. I think it's very important to admit when we don't know things. And we should encourage thinking out loud as well, right? When we ask our learners questions on rounds, we're using a technique called forced delayed recall, right? If we're asking them a fact-based question, it means that they're being forced to recall that fact when they have not just immediately learned it. And it does increase the retention of that information, even if they answer incorrectly. Now, I have a point here, trying not to allow learners to overstep, meaning you don't want one learner on the team to be answering all the questions and making everyone else feel that they're inadequate or that they can't get a word in. So what I do, and there's other ways to do this, is to ask one learner at a time, one question at a time. If they don't know the answer, I don't go around the room. I just say, that's okay, here's the answer. It has still accomplished its educational objective, and then I move to the next learner, right? Or I may take the group of medical students and ask a question of them, and if they don't know, I'd say, that's all right, here's the answer, right? And then I move maybe to the interns or to the registrars and then senior registrars, right? So you want to preserve, to some degree, the hierarchy that exists, in the sense that you don't want your medical students dominating the conversation, or you don't want their fact-based knowledge to make your residents on the wards feel in some way inferior, but you do still want to use this technique because it reinforces knowledge. And when you're asking questions, I would really encourage you to use ideas that are based in higher levels of thinking, okay? So I'm going to start at the bottom right of the slide. This is Bloom's taxonomy of education here, which I really like. We should not be asking them what questions. We should be asking them how and why questions as much as we can, because I don't really care as much that they can retain facts. They can look up any fact on their phone quicker than I can ask it. But they can't, on their phone, understand the proper treatment for the patient in front of them, and they can't understand the mechanism and pathophysiology of the particular patient's condition, right? So we want to help them move from remembering and understanding things to applying, analyzing, evaluating, and then creating plans. And so instead of saying, well, what's the most likely cause of infectious diarrhea? We might say, why do I care which organism is causing this patient's diarrhea? And it's a multi-step process, and they have to think, well, why do I care about that, right? If it's most likely going to be self-limited, what's the point of actually thinking what it is, right? So that's a more challenging question. Or why do you think this patient has inflammatory bowel disease, right? They're going to have to give me some reasoning behind that. Now, moving to the left side, the text on this slide, apologies for the busy slide, I think it is a true phenomenon that learners can feel quite intimidated when they're being asked questions in front of their peers. This is a significant problem with my learners in the US. They, I think, are perhaps expected to have a little bit gentler educational experience. I was delighted to be able to join wards rounds this morning at the National Hospital, and very, very pleased to see quite a bit of bedside teaching and quite a bit of bedside questioning of learners as well. Often when I give this talk in the US, I'm having to convince people to go to the bedside, and I'm having to convince them to actually do bedside teaching instead of just sitting in front of the computer, which is a sad reality that I'm not going to say any more about. So I don't think I have to convince you that you should go to the bedside or that you should do bedside questioning, but you do want to do it in a way that is the most effective, right? So you may want to consider neutralizing questions or phrases. You may want to say to your learner, I'm going to ask you questions on rounds, but it's not so that I can evaluate you, it's so I can teach you, because you're going to learn better if I'm asking you questions about your patients, right? Or, again, using that technique that I did before, don't ask a learner a question, and if they don't know it, turn to somebody else and say, well, do you know? Because then the person one, what they're taking away from the experience is, I'm not very smart, rather than what they should be taking away, which is the answer to the question, right? again, formulate those questions to push the learner to the next level of thinking, higher on Bloom's taxonomy. If you ask them a what question, follow it up with a why or a how, right? And then I think it's actually interesting to allow reverse questioning or discussion. And so I might say to them, okay, suppose I tell you that I think the patient has, acute infectious diarrhea as opposed to inflammatory bowel disease. I want you to question me about that assertion, right? And allow them to ask the questions. It also is a way of teaching the thought process, right? So I have 2 articles screenshotted in the top right here. The first is a satirical article by Fred Brancati, who was on faculty at Johns Hopkins for a long time, called The Art of Pimping, and it's deeply sarcastic, it's very funny. But the more serious paper with a very provocative title, Socrates Was Not a Pimp, which is actually a lovely article about a lot of evidence-based strategies, adult learning-based strategies for using questioning in the context of bedside education. So, we should all strive to grow not only as clinicians, but also as educators, and I think these are some good tools for doing that. Let's move on. We did get some investigations for our patient, and so let's see what those are. So before I met the patient, he had had the following studies. White count was 8.3, hemoglobin 15.2, platelets 203. His creatinine was 1.2. He received fluids, and then it was 0.9, and otherwise his CMP was normal. And his CRP was 1.4. I think the units may be a little bit different in our lab versus yours. Just noting on rounds this morning, I think this would be equivalent to 14, so not elevated. He did also have a CT of the abdomen, which our emergency department, I think, maybe overuses a little bit. And he had thickening of the sigmoid colon and rectum concerning for colitis. His CT was otherwise normal, and he also had a chest x-ray. I'm honestly not sure why, but that was also normal, right? So this is another opportunity to make your house staff or your medical students think, right? As they're presenting the labs, maybe after they're done presenting, ask them, what do you think about the creatinine, right? Force them to tell you a story about it, right? This 1.2 is normal. Is the drop of 0.3, is it dilutional, or is it actually an improvement in the context of dehydration? These are very basic things, but for your first-year medical students or for those who are just starting out, these may be important concepts, right? For your more advanced learners, you may say, why do you think the CRP is normal? In the context of an obviously inflammatory syndrome, right? And you want them to think about that differential diagnosis and consider, certain disease states that may cause a falsely low CRP, and also the limitation of the test, right? And then in this case, for the imaging, I think you might ask them, why did we get this, and did we need this, right? Does this add anything to our differential diagnosis? We knew clinically that the patient had colitis, right? He had diarrhea, he had hematochezia, he had abdominal tenderness, he even had, on digital rectal exam, pain, which would signify proctitis, right? So did we need the CT scan? It may not have been their decision, right? You don't necessarily, this is a multidisciplinary effort, and in this case, the emergency department had ordered the scan. But you at least want to take them through the thought process. And then similarly, the chest x-ray. I think they had been, again, a little bit more worried about inflammatory bowel disease as opposed to acute infectious diarrhea. And this was a really nice opportunity for us to talk through, why do we not think that this is, in fact, inflammatory bowel disease? And they had interpreted the patient's sister also being ill as a positive family history, which I interpreted to be a close contact from an infection, right? And so we were able to talk through that and have a nice discussion about it, right? Okay, and so then we do have a diagnostic test. But you also, even if there is a test that is positive that gives a diagnosis, you really want to go back to the history and physical and ask, what's the pretest probability, right? Does this test have adequate characteristics to either rule in or make a diagnosis? Or does it have, if it's negative, a negative predictive value that it would exclude the diagnosis of concern, right? So you should teach them. Every test has false positives and false negatives. We can be teaching this in the context of the patient's care without eroding the patient's trust in what we're doing, right? It's important that the patient also understands sometimes that our judgment is as important as a technology-based test. This is a really important concept, both for our learners, but also for our patients, right? Your patient comes in with abdominal pain, you make a clinical diagnosis of cutaneous nerve entrapment, and they say, well, why didn't you do a CT scan, right? So if you're teaching your learners at bedside why we don't need the scan and the value of the clinical encounter, you may also be teaching the patient at the same time and helping to build trust, right? Obviously, you don't want to do it in a way that makes your learners seem like they don't know what they're doing. So certainly an art to this, but it is something that can be done, right? And then as before, we want to reinforce concepts of pre-test and post-test probability. If our pre-test probability is low, it takes a very, very good test to subsequently make a diagnosis. And then also teaching situations in which a confirmatory test is needed or not, right? So in this case, we didn't need the CT scan, frankly, and it's important for our learners to understand that. But we do need microbiologic diagnosis if we can get one. And the reason is that the pathogen will change our management, right? If this patient has Shigella, we should treat it. That's guideline-based. If they have Shiga toxin-producing E. coli, we should not treat it because it increases the risk of HUS. This is still a young man compared to most of my patients, and he has risk for that, right? And there's other organisms that we would certainly want to go ahead and treat. So this is why we should follow up, if you have the ability to do it, to get a rapid diagnostic test. And in our case, we were able to get the stool bacterial nucleic acid test, which ultimately was positive for Shiga toxin. And so the diagnosis at that moment was dysentery due to either Shigella or enteroinvasive E. coli. Subsequent culture, which is not on the slide for some reason, did grow E. coli. And so the patient was discharged and did very well. So I hope that this case and the discussion along the way has helped to clarify some of the ways that I think about teaching clinical reasoning. It's not just in the classroom, it's not just on podcasts, and it's not just an isolated thought process that we do outside the context of the care. If that were the case, then a computer very soon would probably be able to do it just as well. But it's something we do as we're taking care of patients, and it's something we learn in the context of their care and as we're hearing about patients and seeing them with our learners. Here are my references, and I think I will stop with that.
Thank you, Professor John Woller, for that very thought-provoking presentation, and thank you for highlighting the importance of the basic skills in information gathering, the thought process, and asking higher order questions, and also very interestingly about reverse questioning that may not be observed sometimes in settings like Sri Lanka, so very interesting. Thank you very much.
So we move on to our third speaker, who needs no introduction. I think everybody has heard his CV, but let me tell you, for those of you who have joined us from abroad, well, when the Faculty of Medicine of the University of Colombo was undergoing curricular changes in the 1990s, we set up a center for what we call MEDAC, Medical Education Research and Development Center, and Dujeepa was the first recruit there. Then thereafter he moved on to greater places, Singapore, and now with the WFME around the world. So Dujeepa, it's always a pleasure to have you. And I was just thinking here, reflecting that this may be the first time that I get to sit with the three of you, the pioneers, as it were, in medical education in our faculty, in one podium, on a day. And so it's a special feeling sitting here as the Dean of the faculty. Over to you.
Thanks, Vajira. Thank you for that kind introduction. And also, first of all, I feel very honored and privileged to be here. And I want to thank especially Professor Prasad Katulanda and the organizing committee for inviting me. My presentation is on the Shaping the Future Physician, the Humanism, AI, and the Art of Clinical Wisdom. And it's quite a challenging topic to deliver in less than 25 minutes. I did a lot of background research, and I hope I'll do justice today. Well, as Vajira mentioned, I've been working now almost 2 decades at Yong Lulin School of Medicine at National University of Singapore, and also as part of the National University Health System. Most of my time is with the Center for Medical Education, where we promote professionalism and excellence in health professions education. So today what I will be sharing are some of my own thoughts and also how we embed artificial intelligence, which the Singapore is really embracing into training both the medical students and also the residents. I need to share this as a disclaimer. Most of these, what I share are my own thoughts, unless otherwise referenced. Okay, I want to start off with something that I want to make sure that put everyone at ease, all right? So AI cannot replace human physicians. I want to start with that. It's because it cannot really do human judgment, proper human judgment, replace human judgment, empathy, perform complex and unusual diagnosis, make that very personal, specific communication and ethical decision-making that physicians bring to patient care. So all these things, at the moment, AI is not capable of, right? So very often the question is asked in many of the platforms, will AI replace human physicians? Because the Microsoft, the person who, Bill Gates said that AI will replace. No, not yet, at least. And my simple answer is that autopilot was discovered or incorporated into aviation about 5 decades ago, but that did not replace the pilots, human pilots. And even if you really compare, in 1970s, the Boeing 747, they had 3 pilots and a flight engineer. But in the modern 747, let's forget about Boeing because their planes are falling out from the skies because they put profits over purpose. But let's say a 380, Airbus 380, now it's flown by 2 pilots. So it has, the technology has improved efficiency and also have assisted the humans to do their jobs better. So that's basically what's happening now in medicine as well. Now with that, I want to go back and reflect on how medicine was practiced, just like aviation in the past. Now this particular picture or the painting from Luke Fields right now at Tate exhibition in Britain, in London, shows a physician intently looking at a dying child with distraught parents at the background. Now, this is typical practice of medicine because it was fact and content-based learning. Learning is mostly through apprenticeship and wisdom of the master, following the master, and also building of knowledge through individual experience. And much of this learning is complete when you when you graduate from the medical school or from the residency program. That was in the past. Fast forward to 21st century, this has changed completely. We are developing or graduating our students or residents to think, critically think. And just a little while ago, Professor Foster shared with us about developing this clinical reasoning, moving into the pyramid's upper levels on Bloom's taxonomy. And also we use technology to enhance care and build teams. And this is something really, really important. How do we build team competence? And this is something that now in reaccreditation or recredentialing of our healthcare practitioners, we are really looking at it. Not only the individual competence, but team competence, how well they work as a team. And of course, with the globalization and diversity that is we all see, how do we actually build this cultural competence amongst our physicians? So this is basically the 21st century practice of medicine. So where the humanism and the clinical wisdom comes in. What is humanism in medicine? At its core, it is about treating patients as a whole persons, not just as cases or diagnoses. It encompasses empathy, compassion, and also the respect of patients' dignity. Communication and trust are crucial because patients need to feel heard and understood. Ethical decision-making and genuine desire to help underpin this approach is really crucial. Studies show that humanistic care leads to better patient outcomes and higher satisfaction for both the patients and the providers. And now we focus on the clinical wisdom. Clinical wisdom is the capacity to make good judgments in healthcare by integrating knowledge, experience, empathy, and also the ethical discernment to provide best care for the individual and the patient. So with these two, how do these intersect with the artificial intelligence, right? How do these elements come together where AI can provide powerful tools and insights, but it cannot replace human judgment and empathy, as I mentioned earlier. Humanism guides how we use technology, ensuring it serves the patients and the students' best interests. And human wisdom, or our tacit knowledge, our experience, helps us to interpret AI outputs. The data-driven advice balancing with the real-world complexity and patient-trainee preferences. The most effective care and training arises from integrating all three. So this is where all three come together. So there are plenty of opportunities in education and patient care. I think the most important is, as just like in aviation, it improves efficiency. It improves personalized training and personalized care. It improves diagnostic accuracy. And we have a tremendous opportunity. And I'm going to share some of the things that we have done. And personally, we were involved from the Center for Medical Education as well. So is there evidence? There's plenty of evidence of how AI has improved both the education, training of physicians, as well as patient care. So these are all, right, from surgery to medicine, to medical education, residency care, etc. Right. We have to start with some core principles when we integrate AI to train the future physicians. So I'm going to share 5 basic principles that we need to follow. And this is what we do back in Singapore. First of all, I think the most important is that we have to ensure AI enhances patient care. Whether we use AI in training or in practice, ultimate beneficiaries as the patients. So it has to improve patient care. And I think the most important thing is that it also needs to personalize learning. Decisions must be taken based on evidence. If something is not working, we need to be quickly change it or adapt it so that it improves care as well as learning. The key is number 4, not because I'm part of the Center for Medical Education, but faculty empowerment. Bringing that AI literacy to both our trainees plus the faculty is the key, how we use intelligently and meaningfully this new tool, the artificial intelligence, and of course, guided by ethical standards. So let me share with you some practical applications that we have been using in education for both the undergraduate and residency training at the National University Health System. So earlier, I think Professor Angus and also Professor Woller talked about, shared about clinical reasoning and also assessments, which I'm going to focus on. So these are some of the things that we do to improve the students' learning, especially the procedural skills. These are all technology-enabled tools. Back-end, the AI is the platform, right? So doing the clinical reasoning, I'll go a little faster because I think I may need a little bit more time. So these are some of the things like, for example, the rapid response system, usual, the virtual reality and the mixed reality, the students learning on their own. And we have now gone into gamification in a big way for both the undergraduate and residents. Now this, some of these are still, we develop these as part of scholarship as well, because what we want to see is that systematic approach. We collect data and see whether it really works. So for example, using large language models in grading of scientific inquiry in assessments. Assessments, we are using it in a big way. Generative AI, using generative AI, developing patient education skills for medical students and residents. And this is being led by one of our former Sri Lankan academics at the Kelaniya campus in the Department of Pharmacology, who is now with the National University of Singapore, and also practicing clinician at Kutek Pua Hospital as well, Natasha Luke. And also, there are chatbots where 24/7 they are available for our students. And of course, using it and in assessment, especially the modified essays, how to evaluate, student reflective logs, and to provide immediate feedback as well. I'm going to show you a series of short videos so that some of these things can be seen. So, before that, we are also providing the support, and I'm really happy. Our Center for Medical Education, we are providing a $1 million Singapore dollar grant, and the latest, just last week, these were the awardees, and 3 of these awards went to projects that actually uses artificial intelligence. So we are that serious in using artificial intelligence to improve and enhance training of our next generation of physicians. I think we need a sound. Okay, so I just want to share that some of those, I'm going to go into specifics for residency training or our specialist training in just a little while, but I just want to highlight how we are embracing artificial intelligence in assessments. So from test design, from item generation to blueprinting for adaptive testing, to test administration, especially proctoring and the scoring, automated scoring and psychometric analysis of the data, plus immediate automated feedback. These are all run with the back-end artificial intelligence. Not only that, we have incorporated this into quality assurance to ensure that we meet the accreditation standards as well. So I just want to quickly share with you how this is done, because again, it is my team who gets involved in the accreditation of the medical school. And let's say we have our own ChatGPT. Now this is within the School of Medicine and the National University Health System. And why it is important to have our own ChatGPT, because we can upload all confidential documents like the student performance data, faculty performance, assessor performance data, the blueprints, the exam questions, how the exam questions, the analytics, everything into this in a secure cloud platform. It will not go out into the general analysis or artificial intelligence that is available in other places. So this is very secure. So I can use anything, and I can personalize it to my GPT, right? So for example, this is my own ChatGPT, and I can ask anything based on whatever the things that I have uploaded or what the school has uploaded, or the university, the hospital residency program has uploaded. As I mentioned, my team is also involved in the quality assurance and accreditation and the continuous quality improvement. And we have developed a special customized chatbot. This is called the AI for Curriculum Review. And this, all our blueprints, our content, our syllabi, everything we have uploaded into this. So this bot assists educators and curriculum committees in analyzing and enhancing academic curricula. Where are the gaps? What are the enhancements? Are we on the right track? is this particular cohort developing properly, or there are any gaps, etc. So for example, I can type in and say deeply analyze. On the bottom, you can see the prompt. Deeply analyze Year 1 Yong School of Medicine curriculum and identify the areas that comply with Singapore accreditation standards for undergraduate medical education. Next, identify the gaps, non-compliant, and suggest how to improve based on our curriculum blueprint and assessment blueprint uploaded. Which in just a couple of seconds, it gives me, this is only part, the whole thing, where the strengths are, where the gaps are, where we are compliant, where we are not compliant, and why we are not compliant. And then I type in, based on the above output, prepare a draft self-review report for MOH Accreditation Committee to refer to the template provided by the Ministry of Health. Because Ministry of Health is the one that accredits medical schools in Singapore, not the Singapore Medical Council. And then immediately, it gives me the self-review report. Now this has cut down. Now this is not the final report. This is a conversation starter. Once I get this, I send it out to all the stakeholders, the heads of departments, the chairs of the undergraduate curriculum committee, chair of the faculty assessment committee, to share with us whether they agree with that or what are the things that needs to be done. Previously, months of work, now we do it in a couple of days. So it's a conversation starter. It's similar. Again, my team needs to, in Singapore and US, all exams must be audited, and my team does the audit. Previously, this audit was done manually. Now it is entirely run on deep learning algorithms and AI-enabled platforms. You see, it has cut down almost 550 working days. Previously, we had about 30, 40 people working on these audits manually. Now, only 2 people are there in the entire team, and it has cut down the number of days. With that, I want to quickly go into actual residency training, how we are using AI in residency training, and also in healthcare at National University Hospital.
Advancements in AI has been revolutionizing the healthcare industry, and NUH is leading this transformative journey. By pioneering and integrating cutting-edge AI tools and platforms, we not only boost operational efficiency, but also elevate the standard of care for our patients. Reshaping the practice of medicine are 3 AI innovations developed in-house. The first is CalSense, which flags out hypercalcemia, or abnormally high calcium levels in patients.
These patients who do not receive timely treatments
may suffer from complications such as osteoporosis, fractures, kidney stones, kidney failure, mental disorders, and even sudden cardiac death. By automating the detection, CalSense enables early detection, diagnosis, and treatment. This offers patients a better chance for a positive outcome.
The second is Pathfinder, that provides real-time insights
into patients' wait times at the emergency department and bed occupancy rates. By tracking current statistics and forecasting patient turnout up to a week in advance, it allows us to adjust manpower allocation and streamline patient admissions. Last but not least is Missy, NUH's first multifunction assistive robot in patient care. Designed by nurses, pharmacists, researchers, and engineers in collaboration with external partners, Missy combines AI large language models, cloud robotics, and contactless sensor technology. It can handle tasks such as recording vital signs and monitoring patients at risk for falls. Missy can relieve nurses of repetitive routine tasks, allowing them to dedicate more time to personalized treatment and patient engagement.
As doctors in NUH, we can use Russell GPT to summarize lengthy patient notes to take note of potential complications so we can safely decide on the right imaging tests.
As doctors in NUH, we can feed Russell GPT prompts to obtain the necessary information to get up to speed on our patients' conditions so that we can provide timely treatment.
As doctors in NUH, we can tap on Russell GPT to churn out memos for patients to bring to their GPs for post-discharge care.
As doctors in NUH, we can use Russell GPT to automatically generate referrals to specialists from other departments who can help us with managing our patients for other diseases.
This helps to save time for our junior colleagues.
As doctors in NUH, we can use Russell GPT, our AI chatbot, to free up the time we have to spend on routine paperwork, so we can engage with our patients more and have a better work-life balance.
Okay, I'm going to go fast because I don't have much time. This is another very interesting one on use of hollow medicine and AI-generated care. So one of the key things I wanted to share is that these are all governed by policy. There's a national strategy and a national policy. And for each and every intervention, like for example, I'm taking for education, how we use in teaching and learning, assessments, and also patient care. There are very clear policy guidelines. And here I want to actually to congratulate Professor Prasad Katulanda and the CCP for taking that initiative to develop the white paper on AI. I think that's a real important part of developing and use of AI in your own settings. Well, there are many problems or resistance to adopting AI, but I want to focus on one very important area that has been highlighted. And this particular study came out in the Lancet about a week ago, where there's evidence showing that significant negative correlation between frequent use of generative AI and the loss of skills as well as critical thinking abilities. It is more pronounced in young people, and the likely mechanism is cognitive offloading. So what are these? There are two things, two areas that we need to focus on: de-skilling and mis-skilling. The key lies in how we train and support, I think I went, de-skilling and mis-skilling. The loss of existing professional, de-skilling is loss of professional skills due to the over-reliance on AI. And the mis-skilling is acquisition of wrong or misplaced skills, focusing more on AI operation than the core clinical judgment. So how do we mitigate this? Well, I think the very first is that the curriculum redesign. We need to integrate AI literacy while safeguarding the core clinical competencies. And this is something that we are really focusing now after leveraging a lot on AI. And then we have AI off practice. Some of the foundational skills must be trained without the use of AI. And then the clinical appraisal training, well, we need to give the basic knowledge of AI literacy, not only to our residents, our trainees, but also to the faculty, so that they can identify when the AI output is wrong, right? And then, of course, evaluating both the AI-assisted and the manual performance together. I think the most important is the last one, continuous upskilling of through CPD for both the practitioners and also for the residents, because AI is fast changing and we need to upskill. What we learned maybe about 3 months ago is completely changed later on, and that's something that we are also discovering. So AI should augment, not replace professional judgment, and training must ensure that the clinicians remain skilled, adaptable, and critical users of technology. There are different ways. Again, the Lancet, again, couple of weeks ago, have put out how to use AI appropriately. There are a few other such things, so we need to kind of properly put our framework in the training itself. And for School of Medicine and the residency program, we are now bringing AI, a minor in biomedical informatics. Now, this is a mandatory program that all medical students and nursing students must pass to graduate. This builds their foundational literacy skills in AI. Well, I think the way forward is that we need to start with small, scalable, low-cost application, and then improve by implementing data stewardships and local practices, build the faculty abilities and the residents' abilities by micro-credentialing, And the most important is that you need to integrate ethics by design and regulatory literacy. Finally, I think the key is that the leadership, right? Leadership must embrace. So in summary, I think these are the 4 areas, but the last, think big, start small, act now. With that, thank you very much.
Thank you, Dujeepa. So I think again, like a lot there, and we did a special session with. May I invite all the speakers on stage? We can allow a few questions. I'm sure there are those. Yes, and our panelists also, please, Prof. Prof. Saroj Jayasinghe and Dr. Rohana Marasinghe, Professor Rohana Marasinghe, Prof. Saroj, and also Dr. Ashwini de Abrew. We need one more, one more chair on stage, please. Thank you. President himself is bringing it over. So we, Prof. Saroj is Emeritus Professor of Medicine at our faculty. Professor Marasinghe is the Professor of Medical Education at University of Sri Ponnamperuma Medical School. And Dr. Ashwini de Abrew is one of our young medical educationalists in our Department of Medical Education. So over to all of you. Any questions from the audience? I'm going to pick up people from the audience. Professor Tershi Chang, you are edging to ask a question. Yes. Yes, please. No, the mic is here. Tershi, please come over.
First and foremost, thanks a lot for the 3 speakers. It was such a fantastic session. I learned so much, and it'll probably change my practice in bedside teaching and clinical reasoning. To Prof. Woller, about, when you do the bedside teaching, we would like students to learn how to learn. So often I think, I don't know, I'm going to change my practice after this talk, but I ask students the question, and you said you give the answer to them. But sometimes it's my practice to ask them, why don't you read it and come and we'll discuss it tomorrow? So that I want them to go and do the searching for the answer, make sense out of it. And as you say, it is more clinical reasoning, it's not just recall. So I will ask them, how do you work this out? How do you differentiate between diagnosis A and B? Read it up and we'll discuss it tomorrow. So I don't give them the answer unless they generate an answer. Do you think that is correct, or should we change that, or what do you do?
Yeah, I think that's a wonderful practice. My issue is that I forget to follow up the next day. So if you do that, if you see a lot of patients and if you're telling them to look up a lot of things, right, you do have to follow up and ensure that you actually hear the answer the next day, both for the benefit of the entire team and, of course, for the learner. But I think that's actually even a better approach than what I had suggested, because it actually delays the recall for the rest of the team by another day, which further enhances the learning. So yes, I think it's a wonderful practice. I think it's the only thing that I would say is important for the benefit of the whole team is that you actually follow up and do it. But if you do that, yes, I like that practice. I think it's really lovely. And a way that perhaps they could be encouraged to incorporate AI into their presentation the following day in a constructive rather than a destructive way as well.
Can I just sure. Add on to what Professor Woller said? So basically this is the developing of clinical reasoning, and clinical reasoning, there's a lot being written by 2 people, Hank Schmidt and A.K. Block from Netherlands. Now, one of the things, just the way that you approach, you need to see it as a kind of, again, as a part of a journey of developing clinical reasoning. So if you the way that you have asked them, go and read and then come back, that is for a kind of a student at a novice level or advanced beginner level, right? Because they're still developing their, what we call the knowledge nodes, connecting the neural nodes, encapsulating the knowledge. They have still not developed what we call the unstable illness scripts yet, right? So for a junior student, maybe year 3, that's a very good approach, right? So they go read, they learn their knowledge notes, link up disturbing. Okay, link up the networking, etc. However, if the student is now doing a professorial, I think the reverse, what Professor Woller mentioned. Okay, this is the diagnosis. Now tell me why that this is the diagnosis. This is the management pattern. So you are deconstructing, right? So they have to now, they should have what we call developed those illness scripts, at least the core illness scripts. Now you're actually checking whether those core illness scripts are unstable or they have developed properly by deconstructing. You're going back with their clinical reasoning. Now, if a student can do that, they have really grasped the content knowledge. So for a student who is an advanced level, it should be better to deconstruct and see whether their clinical reasoning is proper, what are the gaps and why it is so, rather than asking them to go read up and come. That means that they're still at a very early stage of development.
Yeah, that's the issue. I mean, the ground reality is we have final year students who are professorial. Now, I have taught them in a lecture just 2 months earlier, like what's the blood pressure control in a patient after a stroke. And the patient is right there with a stroke. And then you say, okay, which medication, what you do? And they can't recall a thing. The whole group, say 15 students. Now, taking reasoning beyond that, you have to have some baseline knowledge. Even the recall is not there. So there is a huge gap there. So what you're saying is true, Dujeepa. I agree with you wholeheartedly. But the issue is, like, I give them the analogy of bread and butter. You need butter on your knife to apply. But if you don't have the butter, then you just have a plain slice of bread. Yeah. So I say, go and look up the butter. I have taught you exactly, in a lecture we give clinical scenarios and say patient comes, stroke, blood pressure within these hours, what do you do? Yeah. And, they just give, and they start guessing, actually. Yeah.
No,
they say,
absolutely.
I would do this, I would do that.
Very true.
I said, no, why are you reading this wrong?
Just very quickly to respond, because there's no time, and we have a batch reunion in Vaskadua, so I need to go there. So, this is not criticizing you or anyone else. I mean, you are one of the highly rated and loved faculty members in Colombo. But what I feel is that it's the way that the learning design, right? Because we need to design our learning process. Now, I'm sure that you all love Charlie Brown. So there's this very famous Charlie Brown cartoon where Charlie Brown, what's that girl's name? I forgot. Lucy. Says, Lucy, look, I taught, what's the dog's name now? I forgot. Snoopy, yes. Yeah. Completely forgotten, yeah, right? I think that Bill upsets me. So
yeah, the recall problem.
Yeah, Charlie Brown very proudly tells Lucy that, look, I taught Snoopy to whistle. And then Lucy with big eyes goes in front of the Snoopy and then looks at it and said, the Snoopy is not whistling. And it comes back very angrily to Charlie Brown and says, he can't whistle. Then Charlie Brown says, I said I taught him, I didn't say he could whistle. Right? So I think it's a design program. At Yong Lulin, we have done away with all didactic lectures. There are no didactic lectures anymore. It's all small groups. And I think if you want to learn, maybe Oxford, they do it beautifully through their colleges, etc. As you know, you did your PhD there. So I think we need to get them to start thinking. And there's enough more and more material now online. And if we curate it and say that this is the background and you timetable it, it's in the timetable. And we have done that from the very didactic, just like in Colombo, just like in Sri Lanka when I was a medical student, we have completely changed this. And we have put that time in the timetable that they have to do those pre-reading, etc. But when they come to the class, it is what we call a CLC, collaborative learning cases. Very similar to Cambridge and Oxford kind of, tutors actually take them through and ask them things. And you can see that how they improve brilliantly.
Thanks a lot. Thank you.
Thank you. Let's move on to another question.
Hello. Thanks for a very entertaining and very informative session. I'm Dr. Birada from Adelaide, Australia. I just want to make one comment. Like I always tell my trainees and students, like everybody is swearing by AI so much nowadays that I always make them realize that soon I think we'll stop using the most powerful computer we have, and that is our brains. And my question would be like, with things changing so rapidly and quite different to the way we were trained as when we were medical students to become doctors, and highlighting even we see the same problem that nobody in ED can diagnose anything what happens in the abdomen without a CT. Would how we assess medical students and the examinations for the future, should we think of changing that?
Prof. Angus. Dujeepa?
Okay, sorry. Okay, so again, as I shared, one of our core approaches, I mean, we are embracing AI in a big way in teaching, learning, and training, even the residents, right? But as I mentioned in my slide, we have AI off training. Now, AI off training is basically focusing on those foundational clinical skills and clinical reasoning. They cannot use AI. It is face-to-face, real-time, with patients, etc. And they are assessed also longitudinally through multiple workplace-based assessments on an online portfolio. We call it the programmatic assessment. Lambert Schubert and Kees van der Looten shared about this concept. So small multiple assessments to make a value judgment. Is this person ready to move to the next level where they can now use the technology to enhance and improve? Now, without those foundational abilities, we would never allow our student or a resident to use AI. And another thing that I very quickly shared, 25 minutes is not enough, but is the use of patient. There's an AI based platform where they have to start initial management and then use the drugs that are available at NUH in Singapore, the National University Hospital drugs, right? So they learn how to use, what's the first steps, what's the management, how to use those drugs, and they're given immediate feedback. You know, your steps are not in line with the practice, etc. That's how the AI is actually helping. So those are things that we are now using, because what you said is absolutely true, because it can descale or misscale. They learn things wrongly, right? They over-dependence on AI. Thank you.
And I like your analogy about the pilots. I don't think anybody will fly in a pilotless plane. Similarly, I don't think anybody will like to be treated by a robot or just a computer.
Thank you. Let me put our panelists on the spot and tell them one key message that you would want everybody to take away from what you heard, each one. So one each, starting with Prof. Saroj.
Well, it's not really a message, but to reflect on the fact that some of the discussion which we had today looks at things from a very linear perspective. Now, life out there for clinicians is quite complex, and there is no linear thinking which will tackle patients. And this becomes worse with multimorbidity and complex cases we see. And I think we need to look at other ways of thinking, like synthesis, which is required and which is not captured by some of the tests we do and the script concordance. All those are linear, but we still don't have a way of tackling the synthesis part of complex cases. And I think that's the area even AI will not really handle right now. With time, they might do it, but so to reflect on that. Thanks.
Yes, of course, the message I got is that we are at the infancy of using AI, I think, because if I ask a question, can doctor be replaced by AI from human being? I think 100% of you agree, no. If I ask the same question from the AI, again, the same answer. Does that mean the AI uses enough evidence to make that answer, or is that the prompt we have? What do they? We need to think that one as well, because it's still AI is in infancy. That itself, there are different pathways to go. Until that time, I'm sure we all use with careful considerations, like Dujeepa said, very, very systematic way of teaching and learning integration of AI. So that's what I learned. I think that's the correct direction. Thank you.
My take-home message will be not to forget your target audience, the students. They are digital natives. They've grown up with technology, with AI, and they're probably far more proficient than us when it comes to certain aspects of it. So when designing or optimizing curricula and exams, maybe consider getting their input as well as stakeholders. I think we will end up with a better outcome if we do so.
Thank you. So on that note, let me ask my co-chairs to say the concluding remarks, and then we'll wind up. Prof. Indika.
Thank you. I was actually thinking based on the concerns that were raised by Tashi and several others. Now, based on my new responsibilities in the University of Colombo, I was actually thinking, are we putting too much burden on our students? Now, a lot of thoughts, a lot of discussions about students' inability to come out with a rational thinking process. On the other hand, are we putting them on too much content pressure? So basically, they fail to see the trees in the woods. And the information explosion and even AI, are we worsening that situation with that? Could that be the reason for them, that perceived inability to think clearly, think rationally, and come out with a rational decision making? So that's one thought that occurred to me based on some of my recent experiences. Are we giving too much pressure, especially the content pressure, too much content? And can we use AI not to increase, but to reduce that burden? For example, to summarize the huge amount of information, and also to release the burden of content from the students so that they can focus on the basics to work out and rationalize. So those are some of my thoughts. Thank you.
Thank you. Gominda?
Well, what I was contemplating is probably we have now choice, and choice is going to increase, and different students will use that choice differently, and we need to encourage that and guide them, because they may not know what fits them well, but they should definitely have a say on it with the guidance of the faculty. I think that sort of a curriculum probably is the curriculum for the future, which is still at a very experimental stage, but as you say, it's a journey. So we need to experiment on it.
So probably the final message is we all need to change. Medical teachers need to change first. And before we bring about the change that we want from our students, and I think we really need to now focus on what that change is and how we bring about that change, and how we bring about that change in our educational environments, so that the future doctor is both technically competent, is able to use these tools, as well as compassionate and caring at the end of the day. If we are not that, then we cease to be doctors, isn't it? So with those words, let me wind up by inviting my co-chairs to hand over certificates to our speakers. First, it would be, it's all, May I invite Prof. Indika Karunathilake to give the first certificate to Professor Brian Angus. Yes. Next, to Prof. Woller. And may I invite Gominda to give a certificate to Dujeepa. I'm sure you have done this before. Many times, yes. Okay. And let me invite the speakers and the panelists to come over in front to take a group picture. And also, Prasad, please join us. Yeah. And Praveen, you are the man? Oh, I know. No. Thank you. Yes, the panelists also have certificates. I invite Prof. Katulanda to give them to Prof. Saroj. Prof. Rohana. And Dr. Ashwini de Abrew. Yes. Yes, please come on.